Hi, my name is Matt Rettig. I'm a professor of medicine and urology and the medical director of the prostate cancer program at the David Geffen School of Medicine at UCLA. The scenarios that can arise in this setting are multiple. And one of the key factors in determining what imaging modality to consider is what the PSA is at the time that the patient comes to you with a biochemical recurrence. So for conventional imaging, PSAs that are less than 10 are rarely associated with a meaningful result where we detect the site of disease that's representing biochemical recurrence. Just as an example, if the PSA is less than 10, the sensitivity of a bone scan for detecting occult metastatic disease is only about 4%. And it really doesn't have a very good performance characteristic until we get to PSAs that are really substantially over 20. So the technetium-99 standard bone scan is really not an ideal tool unless the patient has a very high PSA. Similar data might be seen with the conventional axial imaging, such as a CT scan. So the question is, what are the differences amongst the various imaging modalities, novel imaging modalities, when the PSA is low, when there's potentially the greatest likelihood of having a meaningful impact by aggressive intervention? So there are a number of scans that can be done. The most commonly used scans are the fluciclovine scan, also known as the Axumin scan, which is approved for patients with a biochemical recurrence. The other scan that can be used is the PSMA scan, and they have been compared head to head. Should also point out, and I'll go into those data in a second, but I should also point out what the PSA is and its relevance depends upon what the primary therapy was. So if a patient has had surgery, PSAs that start to approach 0.2 and higher are very, very likely to represent true disease recurrence. Whereas if the patient's only had radiation as the primary modality with curative intent, then the definition of a recurrence is a PSA that is at least 2 points greater than its lowest value after the radiation. Of course, it's possible that a patient has a recurrence before the patient meets this what's called Phoenix guideline, where there's the recurrence is the nadir +2. So keep that in mind. But in the most straightforward scenario of just surgery, most of the imaging modalities do not perform very well until the PSAs are starting to reach greater than 2. And we know that in the post-prostatectomy setting, that radiation therapy to the primary is most beneficial with the highest rate of biochemical control and long-term biochemical control when the PSA is as low as possible. And really, we're trying to do the salvage radiation in that setting when the PSA is less than 1.5, and really, we want to do it as low as possible. So the fluciclovine or Axumin scan can be used. Its performance characteristics are suboptimal when the PSA is really much less than 2. The PSMA scan actually outperforms the fluciclovine scan, and we did a small randomized controlled trial comparing those two, and both of the scans were done within 15 days of each other. And it's very clear that the PSMA scan is more sensitive as well as more specific for the detection of early recurrence, both locally, regionally, and even potentially in the metastatic setting. So in general, if the PSMA scan is available, that's what you should do. If not, we would do the fluciclovine scan. The PSMA scan, as I said earlier, is really not something that is universally available and is only FDA approved at 2 institutions currently in the United States, UCLA and UCSF. So that's my approach. I tend to use the PSMA scan because I have access to it. And if it's not available, or you can't get coverage for the PSMA scan, or it's too expensive, then I would use the fluciclovine or Axumin scan to try to detect occult disease. It can't hurt to try to do these scans when the PSA is low. It's really important to try to capture recurrent disease and to initiate treatment as early as possible. So that's my approach to the diagnosis and management of biochemically recurrent prostate cancer.